Top Med Talk.
Nick Majerison here, welcome to Top Med Talk. This piece is taken from the 8th Australian and New Zealand Symposium of Perioperative Medicine Special Interest Group. Updates in Perioperative Medicine 360, which took place between November the 7th and the 9th of 2019. Hope you enjoy this talk, and if you do, don't forget to check out topmedtalk.com and make sure you subscribe to us on social media as well. More details about that to follow. Before that, let's enjoy this talk. This piece is presented by Dr. Karl Poon, TAVI specialist at St Andrew's War Memorial Hospital, physician proctor at Edwards LifeSciences, and senior lecturer at the University of Queensland. He's also an interventional cardiologist at the Prince Charles Hospital, Brisbane. Have a listen. This is part 2 of a 2-part piece.
Good morning, everyone. Thank you to Jill and the organising committee and for the kind invitation and the sponsors. That's a pretty tough act to follow. A very interesting talk. I learnt a lot. I think the electrophysiologist in the cardiology arena, we all concede they are the smart ones. I'm just an interventional cardiologist. So my main practice is really in TAVI or transcatheter aortic valve implant. That's a bulk of my work publicly and privately. And I work at Prince Charles and at St Andrews as well, my private hospital. So these are my disclosures, somewhat relevant to the talk. Obviously, Edwards is one of the main manufacturers for TAVI devices, and the other disclaimer is that my wife is in the audience, unfortunately, so I have to be fairly polite to an anaesthetist. This was a real case just 2 weeks ago at St Andrews Hospital. So she's a lady from New South Wales, and her 2 daughters are both nurses up here, and she's been getting progressively more short of breath and was waiting for a TAVI down in Sydney. And she was supposed to have moderate to severe aortic stenosis, but really when we saw her, there was no question about that. So this was all in the past 3 or 4 months. Now, she came in very dyspneic, and she was quite pale with heart failure features, and she was quite anemic. So there was no question why she was getting more and more puffed, and whether it was an anemia-driven or aortic stenosis-driven. We were working her up. Obviously, with that degree of iron deficiency anemia, we wanted to know why and how she got to be so sick. In terms of the aortic stenosis, these were the numbers. So these are clearly severe numbers, not quite critical, but severe enough with a transvalvular velocity that's high enough, mean pressure, and valve area that's high enough to call it severe aortic stenosis. So as opposed to tack some relevance in terms of the anesthetic and this particular agenda, perioperative medicine, we sought advice from our anaesthetic colleagues, the gastroenterologist and the surgeons, and I think given that she's in active heart failure, perhaps precipitated by the anemia, it was deemed to be a high-risk endeavour to prep her bowels and to go for scopes. So the question was asked of me as to whether we should do a balloon valvular plasti leading up to it so that she can have all the bowel prep that's necessary. And maybe if she does have colorectal cancer or cancer in the gut of some sort, then proceed to surgery after a balloon valvular plasti, which we used to do a fair bit. And the gut surgeon and obviously the nurses or the daughters asked me for other options. And one of the other options, of course, in the current era is really to give her a definitive treatment option such as TAVI. Now, we say this all the time, and I get asked all the time about doing a balloon valvular plasti. A balloon valvular plasti, in comparison to a TAVI, is 90% of the risk, 10% of the gain. For those of you who've asked for a balloon valvular plasti, you get a little bit bigger valve area, a little drop in the mean pressure gradient, but sometimes you can get it to moderate AS, but the problem is the harder you push, the more likely you have prohibitive aortic regurgitation. So you're trading one problem with another. Third option, of course, will be definitive surgical aortic valve replacement and potentially GI surgery. The crux of the discussion centered on how likely it was that she had a bowel malignancy, and the gastroenterologist was reasonably convinced, given that she actually had a negative fecal occult blood just a few months ago. Anyway, as part of the CT, as part of the TAVI assessment, this is crucial, and my wife would attest to that. I spent a lot of hours after hours analysing CT in the same fashion as Steve does a lot of work after hours off-site as well. But this is crucial. This is the crux of a good program, that the operators can assess CT, look at the CT, look for prohibitive features, but thankfully the anatomy was more than suitable for TAVI. For what it's worth, we also looked for solid organ tumour in the gut, but there was nothing. So in the end, given this is the crux of my talk, we did proceed to a TAVI. And on the left, that's the valve being expanded by a balloon on rapid pacing. On the right, that's the final result, where you have a valve working immediately, temporary pacing wire, no paravalvular leak, and no heart block of any sort. So she had a very good result, and to be fair, someone like her could have open heart surgery, obviously, but the surgeon was fairly reasonable. So she did undergo colonoscopy and gastroscopy fairly promptly, but surprisingly there was no malignancy found, and I think she was just absolutely relieved for more reasons than one. If it wasn't for this potential malignancy, I'm sure the surgeons would have pushed me pretty hard to have her considered, to be considered for surgical aortic valve replacement. So that's a good news story, I suppose, a story that was 2 weeks ago. So I wanted to be a bit cheeky and inflammatory, and hopefully there's not too many cardiac surgeons on the floor, and maybe some of the cardiac anaesthetists can convey that to your surgical colleagues. But there's a lot of national conversation now at many conferences and advisory board and steering committee about how we can tackle this problem, how we can focus on patient outcomes, patient selection, rather than cardiac surgeons saying, well, everyone should still have open heart surgery, that's still the gold standard. Mainly because early this year the data has finally come out, whereby we have data that will pertain to the majority of our aortic stenosis patients. That is, 80% of our patients are technically low surgical risk. These are patients who will survive open heart surgery. How is TAVI better? Is it really better? So very quickly, the historical context, this is a fairly clean stenotomy wound in a youngish patient, albeit clearly open heart surgery carries a morbidity, that's a certainty, and maybe mortality. So there's multiple complications that I've highlighted there, but the problem that we have to deal with as a health fraternity is how to deal with the cost. A TAVI is about 23 grand per pop if you get it at the right price. A surgical valve is really only about $4,000 and maybe even cheaper with rebates and everything that Steve already alluded to. So obviously, because it's a fairly morbid procedure, it led to ideas from cardiologists how to do a percutaneous procedure. And this was the original sketch, in fact, from Professor Alain Cribier from Paris in 1990. Original sketch, and I'll show you the valve that we use now 30 years down the track, and in fact, it's very much similar. He was a pioneer and remains a pioneer and national treasure, really, teaching around the world. But that was his idea originally, and this is in fact what my career is based on, and what a lot of TAVI operators have to be grateful for. Obviously, it took decades to get to the first clinical case, and that was a bit of a perfect storm for a youngish patient. He was in the 50s, multi-organ failure in Rouen, and he has his very first clinical inhuman implant was in 2002, almost 2 decades ago. This was actually the first case done in Columbia in New York. This is very different to how we do it now. Obviously, this is an integrated approach whereby you go through the femoral vein, go through the right atrium, do a transeptal puncture, go to the left atrium, then through the mitral valve apparatus, then back up the LVOT, then into the aortic valve. The valve was quite bulky, quite short, but they nailed it, and patient survived the initial insult. But this was in fact all done under local anesthetic, and as you probably know, there's a whole swing towards local anesthetic procedures for TAVIs now, although I don't subscribe to that, with all my anaesthetists being very helpful and available. So we talk about this all the time, and every time I give a talk, it seems a little bit confusing. When we started the TAVI studies, we focused on patients who would not survive surgery, high risk or inoperable. That's the first study. The second lot of studies focused on intermediate risk. So these patients had a predicted surgical or Society of Thoracic Surgery American database where their 30-day mortality was predicted to be 48%. And we spoke to the surgeons. In fact, when we were in the US, we participated in this, partner 2. And we had the surgeon to give us the blessing. Sure, we can randomize this patient could have surgery or could have TAVI. So that was a second lot of studies. Intermediate risk. And then this year, the low-risk data finally came out, presented in March to much fanfare. So this is what I mean by low-risk TAVI. It's really low-risk surgical candidate who could have surgery or TAVI in a randomized fashion, those studies, apart from Notion, which was a couple of years ago. But on the left, in the red writing, that's the proportion of patients in the US. 80% of patients are generally low risk for surgical valve replacement, but the bulk of the patients. If you take a step back, people like Martin Leon and Greg Stone, who pioneered this, who brought this from Alain Cribier to the US, their goal 15 years ago, I'm sure, was this. Ultimately, we have to prove and prove methodically that ultimately, one day, any aortic stenosis patient can be treated with TAVI. And I think we owe it to the trialist to design in such a fashion that's not too confronting to surgeons, but ultimately patients will be better served by a minimally invasive procedure that is TAVI now. But the risk score itself is quite flawed, unfortunately. These are just some examples of the risk that's calculated and predicted. Surgeons generally will not like the patient on the left, even though it's technically low risk. Higher risk, but younger patient, bicuspid, probably should be treated with surgery rather than TAVI. As opposed to the lady on the right, even though the STS score is quite high, she's extremely well functioning, and in fact, some of the surgeons certainly would prefer to do her than the others. Just the data that's in the New England Journal, to much fanfare to cardiologists early this year. And there's people like Gene Bronwald saying it's practice changing, and these were some of the quotes that he was putting out there. But the two main trials, Partner 3 and core valve or evolute low risk data. I got to the lay press, and that's fairly inflammatory, I thought, from the New York Times, that they don't need surgery, and I've even read one where they say, patients are having unnecessary surgery, so fairly colourful languages, but I'll try to temper that and be fair in my talk. So he is supposed to be our poster boy for TAVI. Not sure how you feel about that, but his concept was delayed and so on and so forth, and he came back within a few months. So Partner 3, a randomized study, 1,000 patients over a year or two of enrollment in high-volume operators or centres. Patients randomized to S3, a balloon expandable valve that I use in surgery with tissue valve. The data is pretty robust and really self-explanatory. The mortality is 1/3 of open heart surgery. The stroke rate is 1/4, and this is what I tell all my GPs and referrers. It's hard to argue with that. And in fact, most of the surgeons who are now on board would find it difficult to provide informed consent without alluding to this, or patients will come to us even without me prompting. they would ask the surgeon, clearly there's a less invasive option that is, at least in the short term, better off. Why must I have open heart surgery? And the only reason is, your private insurance is not going to fund it. The government is not there yet. We used to have a lot of penalty in pacemaker and think partly device-related, experience-related, and operator-related. But vascular complications low, obviously lower with surgery, because they do count aortic vascular complication as a major vascular complication, but paravalvular leak is quite low. And all the charts will tell you one thing: if you survive 30 days, you do as well with surgery than TAVI, which makes sense because anything minimally invasive, your best bang for your buck, probably the best improvement is in the first month. Although, in terms of quality of life and 6-minute walk test, sometimes even with surgery out to a year, you may not get there as much as TAVI. So Evolute is another design which is self-expanding nitinol. So there's a lot of perhaps debate and controversy about what is better. It's still the same in terms of mortality reduction and stroke reduction, 1/3, 1/4, 1/3, 1/4. So it's hard to argue. The pacemaker rate with this particular study was very high, prohibitively high, and those of you who have been involved at the start of TAVI would realize some of the centers were doing 20, 30, 40% pacemaker after the core valves. And my electrophysiologist actually said to me that's unethical when we did core valve. We now know that we have to place the valve a bit higher and choose the valve carefully. There are predictors about pacemakers such as underlying right bundle, but we are a little bit more careful now. The paravalvular leak with this device, however you look at it, is definitely higher than Edwards. The benefit, or the theoretical benefit to this device is really this, that because it's a supraannular design, the leaflets are higher in the aorta, you have a bigger valve area compared to surgery, and possibly compared to Edwards, although there's no comparative data in a trial setting anyway. So in the US, anyone who has tri-leaflet aortic stenosis can ask for TAVI. So in the US, there's a lot more oversight, and in some way I wish we have as well, where you will not be paid if you do something just outside the box. So they all have to have heart team assessment and surgeon in the room, so on and so forth. But anyone can expect a TAVI, whatever risk they have for aortic stenosis. Quick summary about the low risk. Large-ish trials, randomized controlled, carefully adjudicated, neurologist adjudicated, core lab adjudicated outcomes. I'm concerned about the high pacemaker rate, and in fact the primary author, Michael Reedon, said to me his centre was only doing 5% pacemaker for the core valve for Evolute. He was one of the highest enrolling centres, so it makes me wonder the lower volume centres may be doing 25 or even 50. It's quite unacceptable. As Steve said, pacemakers are not benign, particularly over the long run. And when you do it in lower risk and younger patients, you really need to be as good as surgeons. Approval was approved last a few months ago, but these were fairly high volume centres, and I think in Australia there's only a handful of centres that would do more than 100 TAVIs a year, so we have to take that into consideration. But all in all, TAVI is superior to surgical aortic valve replacement in a few of the parameters, and the important ones, stroke, mortality and rehospitalisation. This may not be applicable in Australia. A lot of the centres will do about 50 a year, maybe with a team or two, so each operator may do only about 20, if that. Patients were carefully screened, as you know, in all randomised controlled trials. There's a lot of cases screened out. Hostile annulus, too much calcium, maybe too high risk of pacemaker. Both trials screened out patients, certainly Partner 3 that I was part of. And over the long term, and the surgeons will say this all the time, you don't know about durability. Coronary access is probably true. You have now a cage over your coronary arteries, instead of a surgical valve that's usually low profile. Paravalvular leak, is it really acceptable to have mild paravalvular leak for a lot of these cases? And what about pacemaker? So I think there are clear exclusions in the trials. Pure aortic regurg valve in valve, EF cutoff was 20%, so anyone less than 20%, there's no data per se or randomized data, and bicuspid aortic stenosis. Hostile annulus with a lot of calcification usually excluded in trials like these. And at least in the partner 3, all the cases were done through a transfemoral approach as opposed to transapical, transaortic, transcarotid, or transaxillary. I think it's come to this point where we can start the conversation that TAVI is probably for every aortic stenosis patient. We'll see what the Americans do. In Europe, that's just been approved over the past 24 hours for low-risk cases, and in those jurisdictions, they are grappling with the caseload. And in UK, for example, there's, I think, only about 10 or 15 centres. In Australia, you can just put your flag up and then you can start doing TAVI. And the idea was really to maintain quality. But the downside, of course, is somewhere like St Thomas, there's constantly a waiting list, constantly patients needing, and essentially doctors need more cath labs. But we've been putting up with this TAVI-SEVAR idea whereby low pacemaker rate is acceptable, low or no paravalvular leak is really what we need to aim for. One of the things I talk about that made me somewhat anti-competitive at a national level is that outcomes are driven by experience. So there's a clear-cut relationship between TAVI experience and TAVI outcome, however you look at it. Vascular complication, after about 50 cases, you sort of know what you're doing. Stroke is constantly a problem. It will still be a problem. But that was a few years ago. My boss presented this, published this early this year, so a little bit more contemporary, but still the same thing. This is sort of where we are now, where in a very high volume centre we deal with this problem where we get all the reject cases who still need to be treated, but as you get more and more experience, you get all the high-risk cases, so there's a bit of a tapering off. In the ideal world, each centre should do about 150 to 200 cases. I'm not aware of a single centre this year doing 150. Maybe Prince Charles, but my private practice is definitely not. We'll be tracking 120 at most. So it gives you an idea that the numbers do not stack up in the Australian setting. Why does experience matter? I see operators who don't look at their CT, and it's almost like someone putting in a stent when someone else tells them what to do, or her. You don't have a surgeon who would put in a hip prosthesis without measuring the CT or the X-ray. We play a lot with valve choice and valve type, and there's a surge of non-transfemoral access, and I've already mentioned that only transfemoral is superior to surgery. And I suppose there's a lot of development that we take back from overseas, proctoring and whatnot. This is the goalpost in Australia. You need to do 30 TAVIs a year, but you can just count the assisting. But that's the sort of explosion of sites over the past year, and this is from the company, so this is pure money as they see it. So there are a lot of more sites now, but in the ideal world, like in Vancouver, like with John Webb, you would want one centre for a place like Brisbane. There's about 7 or 8 now. So tissue valves, there's a lot of choices, but you can see the difference between the different designs, and it's very different to your tissue valve. I mean, the only difference is in tissue valves will be, is it porcine, is it bovine, are the leaflets on the outside or the inside, and maybe the metal, but they're all the same. There's a stent post, and then within that there's some sort of tissue, whether it's pericardium or bovine and whatnot. But these are the different designs in TAVIs. Now, you need some cells so that you can access the coronaries, usually above the valve. This will be very difficult. This is a bit easier. but there's benefits and downsides to all these. I've mentioned paravalvular leak. There are 4 mechanisms that we have to deal with: too big, too small, too high, too calcified. So all of those will lead to a bad outcome. So this was done at another private hospital 2 years ago now, but the operators did not recognize that the valve was not on the correct plane here. So the 3 sinuses were not lined up. The valve placed here is low by all definition, but is extra low compared to the right sinus. So obviously when it's so low, there's a few problems. Pacemaker, which somehow they avoided, but a lot of paravalvular leak. So there's contrast going back to the ventricle. In the private sector, you only be paid for 1 valve every 5 years. So they had to send it back to us at Prince Charles, and you can see how much higher the second valve was placed, about 15 millimeters higher. Unfortunately, this is still happening. That was 2 or 3 years ago now, but we still have very hostile calcium, whether it's a valve-related problem or whether it's an operated problem, or whether it's just calcium. This sort of stuff is just unacceptable in younger patients or lower risk. So I think the surgeons are very keen to minimize these sort of occurrences, and it's up to us operators to minimize that. For a long time, we've reassured ourselves that mild paravalvular leak is acceptable. Now, no surgeon would tolerate mild paravalvular leak. You see all the surgical reports, you've assisted surgeons stitching up a valve in there, there's no leak. But we sort of let ourselves go and say, well, mild is okay, moderate is not. But this is just presented a month ago. This is very early data, but my gut feeling is that it can't tolerate any paravalvular leak. So this is early warning sign, and I suppose if we track it long enough, this will be statistically significant. Even mild paravalvular leak with TAVI is not good enough, particularly for low risks. When I get to 70, if I need a TAVI, I want no leak. Pacemaker is also not benign. Steve knows that better than me, but this is to do with sizing and depth of implant. The lower you go, the more likely you touch the left bundle and you end up getting a pacemaker. So this was the case just a few months ago at one other institution where the valve was, I have no idea what they were doing, but it's halfway in the ventricle. So obviously pacemaker that night. Left bundle after a TAVI is not benign. Pacemaker is not benign. That's what we deal with now. But going forward, as we conquer the surgical arena, bicuspid, traditionally excluded in most of the trials. There's various subtypes of bicuspid valve, but it can be done. We've done a whole bunch of those as well. And with the latest device where there's a fabric seal and the valves are a bit bigger, it's been quite feasible, minimizing the need for second valve, paravalvular leak, and pacemaker. So there's more and more data, and carefully analyzed cases can be done. And this was one of the cases we did a few months ago now. You can see there's no leak, and the patient did not need a pacemaker. But you can see that with bicuspid, you may have this issue where it's not fully expanded. We don't know how to deal with it, or whether that's a problem down the track. There's a lot of studies on asymptomatic severe aortic stenosis, whereby a patient is technically has no symptoms, but it's a small minority of patients who have truly severe aortic stenosis. It's not a benign process. You can scan them every 6 months, but your 80-year-old who's not getting out there may not have symptoms. They may have LVEF that's 20% the first time they come in. So I subscribe to this, although I can't do it in the private sector. But if someone's truly severe, I would have a low threshold to consider it. My experience will be the longer you wait, the more calcified the valve becomes, and it becomes very difficult to do a TAVI safely. A surgeon will go in there and cut out whatever calcium they don't like. I don't have that option. So early intervention from some of the cases I've seen probably would have helped. In highly symptomatic patients who may have moderate to severe aortic stenosis, it's important to look at other things that will make the aortic stenosis look less severe, such as coexisting mitral regurg, even right heart failure, and tricuspid regurg. My prediction over the next couple of years will be this: high-risk TAVI such as hostile annulus, risk of coronary obstruction, should have surgery. In the same way, multivessel PCI, 10 stents, probably better off with surgery. I just tried to be inflammatory here, but this was one of the cases my friend in the US had to do. So he's a surgeon, Gilbert, and he had this case where this is a hostile annulus. Whenever you have calcium going into the lumen, you put a valve in, there's a risk of perforation, there's a risk of leak, like a doorstop. On top of that, there's a left main that's quite low, so there's a risk of left main obstruction. So the beauty of social media is, people really can say whatever they want. So surgeons, cardiologists around the world all chipped into this case. I'm not sure why Gilbert put it on, but it certainly started a lot of conversation in terms of, why surgery, why not surgery? And in fact, he did it. He did a TAVI in the end, thinking that, the average cardiologist couldn't do as good as he can, as an American would do. And he actually did all right, except he had to put a stent into the left main. So this is the last part now as I go to the future. These are the valves that we use, and I draw your attention to the leaflets within the valve. These leaflets are above the coronary arteries, this one particularly. So if I was to put a TAVI in the future, the leaflets would shut down the coronary if I just put a valve in. We have no strategy, at least until recently, how to deal with it. This is the valve I use mainly, the S3, so you can just put a valve in usually, but not guaranteed. So that's an intra-annular design rather than supra-annular. There's one way we deal with this for surgical valves, which is actually we lacerate the leaflet, make a tear in the leaflet so that the leaflet is somewhat V-shaped and you allow coronary blood flow. So the very first one was done in Melbourne in a surgical valve in May this year at Royal Melbourne, first in Australia, I should say. So this V-shape will provide coronary blood flow as opposed to this case on the left where the leaflet would obstruct the coronary without that V-shaped laceration. So we did our first one, I think, in the world where we lacerated a TAVI, and this will be presented next week. But it's very difficult to do. It took me 4 hours, and it's a problem that we have created in terms of TAVI and TAVI. We don't know whether it's feasible. So just in closing, some of the other hot topics you can ask me about. Durability. Surgeons will argue that we don't have the durability data. Leaflet thrombosis. Most of my patients just need aspirin rather than anything else. No Plavix, no warfarin. So TAVI's a minimal invasive strategy. It makes sense that we would have good outcomes in the short term compared to surgery. What I'm very concerned about when I put a TAVI in a younger patient now is how to deal with the next TAVI and how difficult it is to get back to the coronary access or arteries. But as you see from the first case, it probably represents a paradigm shift where you don't have to deal with critical aortic stenosis that's somewhat ballooned with a bit of regurg. You can ask for a TAVI for definitive management to facilitate your surgical cases. So I'll close there, and thank you very much.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.